Hello, thanks for joining me to today's video. For today's topic, we're going to be looking at coronary artery disease. So as always, let's start with the actual definition. So the definition of coronary artery disease is whenever there's an imbalance between the oxygen supply of the heart with the oxygen demand of the heart. So one of two things can happen. Either you can get a decrease in supply of oxygen to the heart, and these can be conditions such as atherosclerosis, and actually atherosclerosis is the #1 cause of coronary artery disease. And so in this situation, the actual artery or the vessel actually becomes constricted because of the plaque formation, and so not enough blood can be delivered to the actual heart muscle for its needs of contraction. The other one can be spasm of the vessels. This is also known as Prinzmetal angina, and so again, when the vessel contracts, it's not able to give enough oxygen and blood flow to the actual myocardium. Besides this, we have arterial thrombi. You also have coronary emboli, inflammation such as aortitis, and you have dissection. So this is going to be causes due to decreased supply. However, you can also have some causes that are associated with increased oxygen demand of the heart. So in this situation, the heart requires so much oxygen that it's just not able to supply it with the amount of vessels that it has. And so this will occur in a case of such as hypertrophy. So hypertrophy is when the actual muscle thickens. So there's going to be so much muscle that kind of fulfilling its oxygen needs is going to be impossible. Other things such as catecholamines, you could also put in sympathetics. And all of these will cause some sort of tachycardia. And so in these situations, the heart is beating so fast that meeting the oxygen demands will be very difficult. So this is your general kind of causes, and I incorporated that with the actual definition. There are some risk factors that are important to mention because remember, coronary artery disease is the most common cause of death in the world. So taking a look at risk factors to minimize that is very important. They're divided into modifiable and non-modifiable, and so again, when you have when you divide them like this, of course you want to focus on changing the modifiable ones because they can be addressed. Modifiable, one of the biggest causes is going to be high LDL, and again, this is going to be the primary cause for atherosclerosis. So trying to decrease that LDL below 100 is very important in trying to limit the occurrence of coronary artery disease. Also, low HDL is another cause there. So then we have hypertension, diabetes, decreased activity, obesity, and smoking. So these are all modifiable causes. In the non-modifiable causes, the main one's going to be family history. So oftentimes, patients who do come with coronary artery disease, they'll have some, a dad or a mother or some type of grandparent did have coronary artery disease in the past. So that's something to look into. Males tend to have more often. And people who are elderly, so greater than the age of 65, are also more at risk. So these are just the general risk factors to keep in mind. Now, clinically, how does a patient present? So the way the patient presents is going to be very important. The main presentation is going to be pain. And this pain is a very, very typical pain. And whenever you get a patient with chest pain, the first thing you need to rule out is myocardial infarction, not only because it's so common, but also because it's very serious. So I'm going to go into a lot of descriptors about the pain because the pain is very characteristic, and it's very, very important that you are able to kind of, understand which pain is going to be more likely and some type of coronary artery disease, and which pain is going to be, non-cardiac or some type of other condition. So first, the way the patient actually describes the pain, the character of the pain is very characteristic. So they'll generally describe it as a tightness, some type of squeeze. They might even say there's like a band around it. They might even describe like a knot in their chest. So they won't necessarily be talking about pain necessarily, but it'd be more like a tightness in their chest that they'll describe. Another way they can describe it is a heavy weight on my chest. They'll say that. They'll even say, I feel like there's an elephant on my chest. It might even present as a toothache or a jaw ache because it does refer to those areas. And they might even describe it as a lump in the throat because, again, remember, the neck is an area where it gets referred. Now, there are some ways that patient can describe it which make it unlikely that they're having some type of coronary artery disease. This is if they describe it as sharp or stabbing. So remember, the type of pain in coronary artery disease will be very diffuse, squeezing type of pain. So that's the general idea. Now, what will exacerbate it? It is generally exacerbated with exertion. So whenever they walk or run or do something, it tends to get worse. Also, when they become recumbent, so when they start to lay down, what this does, this increases the intrathoracic pressure, and so, the volume, and so then the heart needs to deal with more blood, and that can increase the oxygen demand and then cause more pain. Also, sleeping. And this is because sleeping decreases the amount of oxygen you have, so this is another exacerbating factor. There are some things that can precipitate it. This can be a heavy meal. They say this might be because of the blood flow distribution towards the gut. That's one reason, but not necessarily known. Cold. Cold may cause vasoconstriction. That's the idea there. And sexual activity, for obvious reasons. And then we have relieving. Okay, so let's talk about radiation actually before we get to relieving factors. So MI, or just coronary artery disease, they do radiate. So these radiating factors, the primary area where you would see it is in the epigastrium. And so this is important because there could be then GIT diseases or conditions also become kind of in the differential. Not only that, but you can get it to the left shoulder, which is particularly common. However, not only can it go from the the shoulder, but it can go all the way down to the arm and even down to the wrist and fingers. So that's something to remember. And I know typically most people think of it as the left arm, but it can present in both arms. So this is also something that does occur. On top of that, you also can get it in the lower jaw. However, the upper jaw is uncommon, and you can also get it into the interscapular space in the back. And finally, this can also present in the neck. So these are kind of the areas where the pain will be referred to. And any of these, again, you do definitely want to take very into high consideration that this might be a coronary artery disease. Now, that's kind of the radiating factors. Let's talk about the relieving factors. So relieving factors is going to be nitroglycerin and even decreased exercise. And so if it decreases with exercise, that's generally, you want to be starting thinking of stable angina if it's relieving in general. Now, timing, most coronary artery disease occur in the early morning. And this is because you have increased sympathetic nervous system activity and you have increased platelet aggregation, which make it more likely to have an MI at that time. So this is generally the pain that you would see. However, some patients don't have pain. They have something what's called an angina equivalent. This is also known as a silent ischemia or a painless ischemia. So these patients are very important that you're aware of this, because these patients won't come in with pain. They'll be complaining of some sort of dyspnea, nausea, fatigue. They might even complain that they're feeling faint. So you need to be aware of this. And the most common person that you would see this in is either someone who's elderly or diabetic. And so this probably has to do with the nervous system or some type of neuropathy that they may have, which doesn't allow them to feel pain as readily as others would. Now, what would you find on physical examination? When you do the vitals, one of the things that you'll notice is that they tend to have a high heart rate, and this is due to sympathetic nervous system, and high BP. And again, that's due to sympathetic nervous system as well. So remember, these patients, because they feel that pain and they're kind of feeling in trouble, they will tend to have a higher heart rate and BP. So on auscultation, what will you find? You do tend to have a S3, S4 heart sound. They also may have a paradoxical S2 split, so that's something to keep in mind. And if there's papillary rupture, they will have a mitral regurg type of murmur. Now, on physical examination, another very important sign that you want to look for is called Levine's sign. In Levine's sign, I have a picture of it over there. When you ask the patient where is the pain, they'll put a clenched fist on the chest. And this is important because they have done some studies that patients who present with this clenched fist on their chest, it's very likely that they might be having a coronary artery disease. So that's a very, very important sign that you do want to look at. Now, when you do have these patients, what sort of investigations would you want to do? Well, one of the first investigations that you want to do, the number one that you want to do is definitely you want to do an ECG. This is the number one investigation, and you want to make sure that you do the ECG as soon as possible. So when describing the ECG and the ECG changes, what I'm going to do is I'm actually going to show a heart here. So this is, obviously the heart. And what I'm going to do is I'm going to draw a actual chest lead, which is right here. So this is the actual lead. And so it's going to be looking at the heart in this direction right here. So this lead is going to look at the heart in this direction. And so obviously the normal way the heart, electrical activity of the heart moves is it goes down here through the bundle of His and then up the left ventricle here. And so as this signal is going through, obviously the lead here is taking a look at it, and so you get a normal ECG here where you have the QRS there and T. And so this is just kind of diagrammatic. It's not going to be exactly like this, but you get the general point. Perhaps this QRS is a little bit too wide, but you get the idea. So what I'm going to look at first is, so this is how it normally looks. This is what we're looking at. So let's first take a look at the initial type of ischemia, which is called the subendocardial ischemia. And actually, subendocardial ischemia happens just under the endocardium, and this is generally the initial type of ischemia that occurs, so subendocardial. So what happens here? So as the signal normally comes down the bundle of His and now it's going up the ventricle, once it hits the subendocardial layer, that's where it's ischemic, it then kind of moves rapidly downwards. And this is, many theories as why this occurs, but the idea is when cells kind of break down, the wall is going to be obviously broken down, and so the actual electrical signal can move much faster. And so what you notice is as it moves suddenly down, it's moving away from the actual chest lead. And so you get, and this current, actually, I should have mentioned this first, this current that goes down suddenly is called an injury current. And again, that's just because of the broken down membranes. The signal tends to move much faster than in other directions. And again, just to reiterate, if you look, this signal is moving in the opposite direction of the actual chest lead, so it'll come out as a negative type of design. And so when we actually draw out the chest lead, of course we have a normal P, then you get a QR, right? And as it goes up, instead of going up to the baseline like it did before, now it's going to go in the opposite direction from the chest lead, and so you'll get an early type of cutoff there, and then you'll get the T wave there. So whenever you have subendocardial ischemia, what you tend to get initially is going to be a ST depression. So ST depression is going to be pretty much pathognomonic of subendocardial ischemia. Not only can you get ST depression, you can also get a T wave inversion. The reason why behind it, not known as well as with ST depression, and again, these are all actually theories, but just remember, ST depression or T wave inversion both signify subendocardial ischemia. So now, of course, if you let the ischemia continue, eventually what will happen is it'll continue onto the entire wall. And so when it continues onto the entire wall, we no longer call it subendocardial, we call it transmural. And so when you have transmural, what happens to the signal? So it goes down like it does before, and this time it goes out towards the actual chest lead. So when it's going towards the actual chest lead, you won't get an ST depression, rather you get an ST elevation. So let's just kind of see what that looks like. So you get the normal PQ. So now it's going down. Instead of going all the way down to base, it goes up and you get the T there. So this is going to be the image when you get a transmural infarction. So you get that ST elevation, which is important to look at. So now, not only can you get an ST elevation, but you can also get a hyperacute T wave, which is also symbolic of transmural infarct. So not only we're going to look at that, so this is going to be in the acute. These are the two that you tend to see. However, over time, you do see some changes. So here, actually, okay, here you go. So what you notice here, what begins to develop is at the bottom here, you develop what's called a pathological Q wave. So what's a pathologic Q wave? What this little dip here, which isn't seen there, this occurs when there is no more electrical activity occurring in this transmural infarct. And so what's happening is, because there's no electrical activity occurring, this lead is going to actually pick up the current that's in the septum. So this becomes actually like a window. And so when you have a Q wave, that means this area is not active at all. So this kind of does have a poor prognosis. You're saying that there's actually no electrical activity occurring. So very important to see this. And this tends to occur with also a R wave depression. Okay, yeah, a depressed R wave. So in a depressed R wave, you see how high it is here, it kind of goes down. So these two tend to occur together. And this generally takes a few hours to begin occurring. So and then what also can happen after a few days is you get a much deeper Q wave and you can get a T wave inversion. So after a few days, you get a much deeper Q wave and you can get a T wave inversion. And the T wave inversion is unique because it can continue lasting for weeks on end. And sometimes some patients will just always have a T wave inversion. And real quick thing, Q waves can also occur early on. That's called an early Q wave, so it's not always going to take hours to develop. And early Q waves do tend to reverse with treatment, so they don't tend to be as ominous as when you get a late Q wave. Okay, so these are just the general different types of designs I guess you can get on the chest leads. Let's talk about the location. So you do have 12 chest leads. So the way I do it to know what location it's in, I kind of summarize it how I'm doing it now. So I'm running all the chest leads here, V1, V2, V3, V4, V5, and V6. So this is how it comes up in the actual, when you have the ECG document. So the way I look at it is 1 in AVL, as well as V5 and V6, these are all lateral. So when these are, when you have ST elevation here, that signifies more of a lateral type of infarct. Whereas if you have 2, 3 in AVF, this is inferior. Finally, V1 and V2 signify more of a septal type of issue, and then V3 and V4 are anterior. So by kind of having this in my mind, this image, I'm able to just kind of look at it and see where the actual infarct is occurring. And the location of infarct is important. Anterior tends to have some of the more worse prognosis, so that's something to keep in mind. Next, after ECG, the next important test that you definitely want to do is you want to do cardiac biomarkers. The different cardiac biomarkers that are available is troponin T, troponin I as well, and finally CKMB is also used. However, troponin T and troponin I are more specific than CKMB, and here we have a nice little graph here which shows how troponin T and CKMB elevate in the blood and go away in the blood over time. So troponin tends to peak right around 12 hours, and it lasts for about 2 weeks. So it's going to be in the blood for a very significant amount of time. CKMB, however, peaks a little earlier, 4 to 6 hours, and it only lasts for 2 to 3 days. So CKMB is a little better in the fact that it does increase quicker and it goes away quicker, so you can detect reinfarction. However, it's not being used much anymore. Troponin is the only one that's used. It just tends to be more specific. CKMB, the only use, if it's used, is for monitoring reinfarction. So besides that, not much use anymore. Next, you can also do what's called a stress ECG. So stress ECG is when you put a patient on a treadmill and you ask him to exercise until he is 85% of his maximum heart rate. So how is maximum heart rate determined? That's 220 minus the age. So you do that factor and you get 85% of it. Now, While they're walking on the treadmill, they will be being monitored on an ECG. So as they're going, what are you looking for? So positive signs that this patient does have some sort of coronary artery disease is that as they're on the treadmill and they're getting closer to that 85% of maximum heart rate, they become symptomatic. So they might become breathless or have some chest pain, or sweaty or tachycardia, or they can have an ECG change. And so the ECG change would be an ST depression of greater than 2 millimeters. Beyond that, any change, drop in BP greater than 10 millimeters of mercury, or any ventricular tachycardia, arrhythmia, these are all considered positive signs. And generally, the earlier that the symptoms appear while they're on the treadmill, the worse the prognosis and the more specific the test, the higher the specificity, meaning that they do have the condition. Now, why would you do this to a patient? I mean, you're thinking they have a heart problem. Why would you want to push them even more? Well, you do these in cases where you are uncertain of the diagnosis, specifically in stable angina. Also, you do this as an assessment. So you can assess their capacity, as well as you can assess how the treatment strategy is going and how they're improving. Also, you want to do this when there's an abnormal EBCT score, the external beam CT score, and we'll talk about that in a little bit, what that is. So, but you do want to do it when that occurs. What are some contraindications? Some contraindications if the patient had unstable angina within the past 2 days. So you don't want to do that in that case. Also, if the patient has any arrhythmias, because that makes it difficult to actually judge any type of ST depression. Any aortic stenosis makes it difficult for them to get that BP, the heart rate up as high. Myocarditis as well. If the patient has uncontrolled heart failure, you definitely don't want to do this. Any pulmonary hypertension or an infective endocarditis. So these are general conditions where you shouldn't be doing this because obviously the patient can't handle any stress on the heart. In these patients, oftentimes echo is helpful. So what an echo can do, it can actually assess the left ventricular function by looking at the wall motion. So oftentimes if it's abnormal, you'll see akinesia, which means that it's not moving or a certain segment is not moving, or dyskinesia, where a certain segment is moving abnormally. So it's not contracting how it's supposed to, maybe it's fluttering or just contracting weakly. What are indications for that? You want to do these in patients who have chronic stable angina. They have a prior MI. You look at the ACG and there's a pathologic Q wave, meaning it's a very poor heart, or they have heart failure. So that's what you want to do. That's when you want to start doing an echo. Now, another study that's being done, which is pretty new, is called the electron beam CT or the multi-detector CT. And what this does is it evaluates the amount of calcium in the coronary arteries. And then based on how much calcium is there, you get an Agatston score. And so why are we looking at coronary calcium? Well, because plaques that have atherosclerosis, they tend to have high calcium as well. So you're kind of looking at how much atherosclerosis is actually in the artery. This is prognostic. You're just kind of evaluating how bad the actual artery is. You're not necessarily doing any form of treatment. And finally, you can do what's called a coronary angiography. In a coronary angiography, what you do is you put a dye into the actual blood vessels of the heart, and then you kind of take an X-ray. And this can detect any type of coronary obstruction, coronary artery obstruction. And so what the picture you get is like this. And so you can see over here, that's the left coronary artery there, and you can see that the lumen is contracted here. And you can also see the same thing over here, and this is the left circumflex. So this not only confirms that you have some type of constriction going on here, but it can tell you where it's occurring. And this is because when you put the dye into the vessels, it actually can outline the lumen of the arteries. And when do you use this? Basically, if you assess for cabbage, and cabbage is when you actually when you do open heart surgery. We'll talk about that in a little bit. And when you want to confirm the diagnosis of some type of coronary artery disease. Okay, so that kind of talks about investigations there. Now let's look at how you manage this patient. So when a patient comes into the ER and he's talking about that typical pain that we talked about earlier or symptom angina equivalent, the first 10 minutes, you have a lot of work to do. So in the first 10 minutes, you want to make sure you do a quick focus history and physical examination, and you want to start them with some prophylactic treatments. So in your focused history and physical examination, you're trying to assess what kind of condition they're in, and you're trying to rule out any underlying conditions or contraindications to some of the medications that you want to give. So one of the first things that you want to do is you want to do your ABCs, and you want to check check for hemodynamic stability, and see if they have any heart failure. Next, you want to ask for any bleeding, any neurological symptoms, or aortic dissection, and this is because this would be then contraindicate any fibrinolytics that you may give. Sildenafil is another thing you want to ask for, and this is because then nitroglycerin becomes contraindicated. And finally, you want to ask about cocaine and ergotamine, and because of course that can talk, then you might be thinking about Prinzmetal angina. And for the purpose of exam, oftentimes if they say the person was at a party, that could, that might be cocaine, or if someone has a migraine, that might be, they might have been taking ergotamine. So just two things that you want to look for. So after taking this very focused history and physical examination, you do want to start some initial prophylactic type of treatments to make sure you stabilize the heart and don't let the plaque rupture or get worse while you're trying to do some of the investigations. So the first thing that you want to do is give aspirin and clopidogrel, and this is also known as dual antiplatelet therapy. And this is commonly given. However, if they do have a bleeding risk, then this is contraindicated. So you may just want to give one, or you may not want to give it at all if they have some type of bleeding risk, either in the history or currently. Beyond that, you also want to give sublingual nitroglycerin, and this is going to cause dilation of the coronary arteries. And just real quick, the aspirin is going to be 160 to 325 milligrams, and that's going to change later in the chronic. But initially, in the acute setting, you want to give aspirin 160 to 325 milligrams. However, with the sublingual nitroglycerin, you're going to want to give them 0.4 milligrams at 5-minute intervals, maximum of 3 times. So for 15 minutes is the maximum they'd be taking it. Contraindications, low BP, less than 90 millimeters of mercury. Again, it would cause vasodilation, so you don't want to worsen the BP there. Also, right ventricular infarction. And actually, you do want to look for signs of right ventricular infarct when you're doing the physical examinations. And so what you're looking for is raised JVP, or even like hepatomegaly or edema in the extremities. Also ask about sildenafil, because that is a contraindication if they've taken it less than 24 hours. So you do want to look for these things. That way you can make sure not to give them any type of medication that would be contraindicated. After that, if the sublingual nitroglycerin should, with the aspirin, clopidogrel, and sublingual nitroglycerin, you should see some changes. If you don't see changes, you might want to consider giving IV nitroglycerin. And this is generally reserved if the pain is still persistent, or if the STT changes have not changed. So those are the two times you want to use this. Oxygen, you only want to give if the oxygen saturation is less than 94%. Also, morphine, you do want to give as well. That will help with the pain. You generally give 2 to 4 milligrams IV, and this will also help control the tachycardia and all those things if the patient is more calmer and more relaxed. The mnemonic for this is MONA. This is what I use. M for morphine, O for oxygen, N for nitroglycerin, and A for aspirin, and now clopidogrel. So you want to think of that as well. Now, what I've also seen given, or seen in the literature, is beta blockers. Of course, this is contraindicated if patients are having heart failure or any type of hemodynamic compromise, as well as if they have bradycardia or some sort of airway disease. But beta blocker is mentioned, as well as giving statins. Now, statins you might want to consider long term, but I have seen them. I have written some books that you want to give immediately as well. So, of course, it won't help in the acute way, but I just want to write it down just because I've read it, but I've never actually seen that done. And then what you want to do is you want to give IV access, so that you can start, pumping the medications. You want to go ahead and order that ECG, and you want to go ahead and order that cardiac biomarkers. And so again, all of these things that I just mentioned needs to all occur within 10 minutes so that you can then go ahead and figure out what's the next step in management. So after doing all of that, then you want to try and classify exactly what type of coronary artery disease they have. So the first thing that helps you is by looking, as we talked about before, by looking at the quality of the pain. So if the pain tends to only be with exertion and gets relieved with rest, then this is going to be stable angina. And so that's the definition of stable angina. So however, if the pain is constant and nothing seems to make it any better, and they're just laying down and it's still painful, then this tends to be known as an acute coronary syndrome. So acute coronary syndromes, these tend to be more serious, obviously. So once you notice that the patient has acute coronary syndrome, you then look at the ECG. If the ECG shows sign of ST elevation, like we just discussed before, that's a STEMI, so STElevated MI. However, if there is no ST elevation, then the next thing that you want to look at is the cardiac biomarkers, the troponin, T and I, that again we've discussed with the investigations. So if the cardiac biomarkers are elevated, then this by definition is NSTEMI, and if it's not elevated, so if it's elevated, it's NSTEMI, and if it's not elevated, then this is going to be unstable angina. So right now what I have kind of drawn out here for you is all the different type of coronary artery diseases. So stable angina when it's only pain with exertion, unstable angina when there is no elevation in cardiac biomarkers, NSTEMI when it's elevated cardiac biomarkers, and STEMI when you have ST elevation, and of course you also have elevated cardiac biomarkers. Now, unstable angina and ST elevated MI, the only difference is whether cardiac biomarkers are elevated. And since we're using troponin, and troponin doesn't peak till about 12 hours, oftentimes you can't differentiate between these two for 12 hours. So if you get the biomarkers within 2-3 hours and you see the negative, you don't want to just think that, oh, it's unstable angina. You want to keep doing them for another 12 hours, maybe like every hour or so, until 12 hours, and then you can safely say it's unstable angina. So let's first talk about the least severe of all these conditions, the stable angina, and what you'd want to do. So the first thing you want to do in stable angina is do a stress ECG or an echo if that's contraindicated. And what this will do, this will help you first confirm the diagnosis and understand the severity of it. Now, if there is positive symptoms in the stress ECG, then you want to go ahead and do an angiography. And so the angiography will tell you again, give you a more detailed picture of what's actually going on in the arteries. And depending on what that gives you, you might choose to do an angioplasty with a stent. So that's actually putting a balloon there, which we'll discuss later. Or you might want to do a CABG, which again we'll discuss in a little bit. You also want to focus on risk factors and minimizing risk factors. And this means keeping the LDL less than 100 and actually less than 70 if they have diabetes mellitus. It also means trying to maintain a high HDL as well. So these are risk factors you want to watch out for. And this can be done by either giving statins or beta blockers. So that's, and of course aspirin as well to prevent any clots. Now, unstable angina and actually NSTEMI, once it's confirmed, you want to try anticoagulating. If they haven't started beta blockers, you want to start on beta blockers, and you want to go ahead and continue the nitroglycerin. And so this is the same for unstable angina, for NSTEMI and STEMI as well, which is we're going to get to in a little bit. So this is generally, once you've known that it's acute coronary syndrome, these is the next step in treatment. Now, when we're looking between unstable angina and STEMI, the first thing you want to remember is you do not use any fibrolytics. So fibrolytics are completely contraindicated, and they can actually make things worse. So what you do use instead of, because you can't use fibrolytics, is you do use a scoring system called the TIMI score, which stands for Thrombolysis Index in Myocardial Ischemia. So what this score does is it helps you determine whether you're dealing with the very severe type of ischemia or not. And so it's made up of 6 factors, and I use the mnemonic America to help me remember all of the different type of things you want to keep into consideration. So the first A is going to be for age. So age greater than 65 will get 1 point. The biomarkers, the troponin levels elevated is going to get another point. ECG showing ST elevation, ECG changes showing the STT changes is going to get another point. Risk factors such as family history, hypertension, diabetes mellitus, obesity, and even smoking. If you have 3 of these, then that gets 1 point. I stands for any ischemia, this like 2 episodes of ischemia within the last 24 hours, any history of coronary artery disease, and if they use aspirin within the last 7 days. So when you apply this score and they get they get a score between 0 to 4 or 5 to 7. 0 to 4 means they're low risk, so they can be managed with medicine alone, which would be the what we're doing up here, the anticoagulants, the beta blockers, and nitroglycerin. And if it's between 5 and 7, these patients are considered high risk and they need to get cardiac catheterization. And again, we'll talk about that in a little bit. So now that we're done with that, we can go ahead and talk about STElevated MI. So in STElevated MI, the first thing you want to think about doing is reperfusion. But on top of reperfusion, you still want to be making sure you're giving the anticoagulates, beta blockers, and nitroglycerin as well. So the question is, how are you going to reperfuse? So the number 1 choice is going to be primary PCI. PCI standing for percutaneous intervention. So this is by far the number 1 choice. You want to try to do this within 90 minutes, door to balloon. However, we will give less than 120 minutes if they're being transported from another facility. Now, sometimes you will do it at any time, no matter how long it takes. Say they're from a very far facility, it's not going to be able to be here within 120 minutes. You still don't care. You still want the patient here because it's just such a great advantage. This is going to be in cases if the diagnosis is in doubt, or if they have a very high bleeding risk, or if they're in shock. So these 3 types of patients, it doesn't matter how long it's going to take, get the patient here so they can do PCI. Also, if the patient has been having these symptoms for greater than 12 hours, in these patients, fibrinolysis is ineffective because the actual clot has become so hardened that it's not going to work. So patients greater than 12 hours, you want them to come in. Now, how does PCI work? So what you can see with PCI here is you have this plaque here. You take a catheter, bring it into the plaque, you dilate the balloon, and so now you can see that the actual vessel has opened up. So this is a balloon angioplasty. We actually increase the balloon. Sometimes they can actually put a stent there, and so there's different ways of doing it, but the idea is you're kind of physically widening up the vessel, and so this is the number 1 choice. Now, if this is another choice that we do have is going to be fibrinolysis. So fibrinolysis is opening up the clot with the use of drugs. However, this is not preferred because it has a high bleeding risk. But when you do use it, you want to use it within 30 minutes from door to needle time. What agents would you use? You can use alteplase, tenecteplase. Is another one. You can also use retaplase and streptokinase. However, streptokinase is considered the most inferior out of all of these. Now, the only time fibrinolysis is indicated is if PCI is unavailable and you can't get the patient to another center within the 120 minutes and they don't have any of these symptoms here. So, you're trying to avoid fibrinolysis as much as possible. Why? Because of the bleeding risk. So, and PCI is just way more superior to that. And also, of course, this has to be done within less than 12 hours. So rescue PCI. So now if fibrinolysis doesn't work, you have to do something called a rescue PCI. When do you do this? This is if the patient has worsening pain, even though he's been treated, if they still have ST elevation after the fibrinolysis, if they go into heart failure, or if they become suddenly unstable, then you want to do is called a rescue PCI, where you go ahead and just go back to the PCI. Now, in certain cases, and by the way, this is I didn't write that here, less than 12 hours. So in certain cases, you want to do a surgery, which was done much more before, but now with PCI isn't being used as much, and that's called CABG. So CABG is coronary artery bypass graft. So in this surgery, what they do is they take a vessel from the saphenous vein in the leg or the internal mammary vein, and they kind of punch a hole in the aorta, and then they so here's a clot here. So you bypass the clot, and so you're able to perfuse the area of the heart there. So this is generally done anytime you have a unsuccessful or a complicated PCI. So that's kind of one of the main reasons we use that. And so this is kind of like a secondary reason. Primary reasons, if the left main artery, so you do the angiography and you see that the left main artery is involved, or you see that there's 3 vessels involved, or if there's a severe, low left ventricle ejection fractions. Also, if the patient has the MI and he develops certain complications, such as a septal rupture, a papillary muscle rupture, or a ventricular aneurysms, you do want to do a CABG, and this is just because you're going to be doing open heart surgery anyways, so you might as well just go ahead and do a quick CABG while you're kind of in there. So after you've done all this, you stabilize the patient. What is the non-acute management? So again, what we talked about earlier was the acute management. That all needs to be done within a few hours. Either do the PCI, the CABG, or do the fibrinolytics, or whatever you need to do. Now, once the patient stabilized, he's in the hospital, he's admitted, what do you want to continue doing? So generally, you do want to go ahead and continue with the antiplatelet therapy. So this is going to be the aspirin. Now you can lower the dosage though, 75 to 100 milligrams. And you want to basically continue this indefinitely. And so this is going to prevent new platelets from forming. You also want to continue the clopidogrel. And if ticagrelor and prasugrel is indicated if any type of invasive procedure was done. Nitrates do need to be continued, and this is going to be prophylactic. And you also want to go ahead and continue the anticoagulants as well, unless there's and specifically you want to continue the anticoagulants if there's any risk of emboli, such as an atrial fibrillation. And so generally what you want to do is you want to do the dual antiplatelet therapy plus rivaroxaban. So, and this you want to, the rivaroxaban you want to maintain for up to 1 year if there's some risk of emboli. And finally, while the patient is in the hospital, you do want to increase ambulation. So you want to get them to start walking around and trying to being as normal and regular as possible. So this is going to be the non-acute management. Then there are certain things you want to keep in mind before you're going to discharge the patient. So before discharge, there's many things you want to do. First thing is you want to take a look at the left ventricular ejection fraction. However, this will be low. It does take a few days to actually go back to normal. So if it's low, don't be too worried, but it's good kind of baseline to get. Also, for many patients, you want to do a stress test, a stress ECG test. This is generally done for patients who had partial or no revascularization. And so what you're looking at is how well of a job did you do? Is there still some ischemia there? And so this helps detect any residual ischemia that might be there, identify some arrhythmias, and also evaluate the patient's exercise level so you can create some type of cardiac rehabilitation program. You kind of know where they're at. It is contraindicated in certain patients to do the stress test on the same day. This would be patients who had full revascularization done, and because it's just not necessary, you know that there's no ischemia there. If they have heart failure or if they have arrhythmias which are life-threatening, in that situation, you want to just go ahead and do an echo, oftentimes for those patients, just to kind of look at the heart and how it's functioning. Finally, discharge medications that you want to give. You want to continue on that dual antiplatelet therapy, plus or minus the anticoagulants that we talked about earlier. ACE inhibitor is a great idea if it was an anterior MI, and if they have any history of hypertension, diabetes mellitus, or chronic kidney disease. Aldosterone antagonist, especially if it's an NSTEMI, is indicated. Statins to lower the LDL, beta blockers, again to decrease heart remodeling. And finally, you want to do some lifestyle changes. So you want to get their hypertension under control, glucose under control, quit the smoking, and then of course get better diet and exercise. And so with that, you kind of continue to monitor the patients and see how they're doing, and then hopefully they do better. So thanks for watching the video. See you in my future videos.